All right, welcome. Good morning. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and I'm thrilled to welcome everybody back to Grand Rounds and to the start of the new year. We could not have a more inspirational or topical guest speaker than Dr. Boyd, who's going to talk to us about pandemics and policy, and we'll get started in just a minute. A few other dates to note. You just want to make sure everyone sees the upcoming pediatric Grand Rounds. Bonnie Maldonado and Rashni are right at the forefront of all the research and clinical work around this pandemic, and they're going to be giving us an update on the epidemiology and clinical manifestations of COVID-19 and update. Just also want to make sure you know that we have a really nice library of probably about 10 or 12 pediatric Grand Rounds from the spring that were specific to COVID, many of which remain very relevant, such as things like mental health, work we're doing in low resource settings. So I really encourage people to go to the Department of Pediatrics website and take advantage of the really wonderful resource of all of those different recordings. I also want to take this opportunity as we kick off the new year to extend our gratitude to the Pediatric Grand Rounds Committee, who have been working tirelessly to make sure we are bringing you the most accessible, the most relevant, most up-to-date information. So that's Lisa Chamberlain, Bert Glader, Neville Golden, Alan Schroeder, Matt Porteous, our chief resident Sam Scanlon, and of course Allison and Serena, who really make it happen every single week. So thank you to them. You can see here we've got another COVID update on September 18th, and then another topical Grand Rounds on the landscape of antibiotic resistance in the United States. Next slide, please. We've refined our technology now, and it's just important for everyone to know that each Grand Rounds has a unique code. So here's the code for CME, sign in to claim CME credit online, and that's the code, but just make sure you know it's unique every week. Next slide. And then before we move on to today's speaker, I want to make sure there's two very important dates everybody needs to get on their calendar. I think you're all aware that the Department of Pediatrics has led on this campus around diversity and inclusion in many, many ways. And I'm sure you all know that Rhea and Carmen got the President's Award for diversity this year for the work around diversity. And part of that work includes the Diversity and Inclusion Forum that unfortunately was postponed in the spring, but is happening. It's happening soon. So Friday, October 9th, registration is open. You can see that our keynote speaker and our plenary speaker. So really a wonderful lineup. So I want to make sure everybody gets this on their calendars since it's such an important part of the program. On a related note, the SPARC, which is the Stanford Pediatrics Advancing Anti-Racism Coalition, is going to be running a town hall. You've helped us identify a whole bunch of really important action items, and we are doing them, and we want to share that with you on September 21st. So another important save the date. All right, next slide. So I'm going to ask Baraka Floyd to introduce our guest speaker. I'm sure many of you are aware with Baraka's work. I'll just tell you a few things and you'll know, it'll be evident why she's introducing our guest speaker. So Baraka leads the pediatric resident training in the social determinants of health and health disparities. She is the medical director for the Family Advocacy Project, a medical legal partnership which teams lawyers with doctors to address the legal determinants of child health. As further evidence of her commitment to the studies of social determinants of health, she's leading regional work for the National Developmental Understanding and Legal Collaboration for Everyone, the Dolce Collaborative. She and others in general pediatrics, a division that's very passionate about this work, have developed tools that tailor and improve access to needed social services for families from low-income ethnic minority communities. So thank you, Baraka, for the work you do every day and for introducing today's speaker.
Thanks so much, Dr. Leonard. I have the distinct honor to introduce my colleague and friend, Dr. Rhea Boyd. Rhea Boyd is a pediatrician and public health advocate and scholar who writes and teaches on the relationship between structural racism, inequity, and health. She has a particular focus on the child health and public health impact of harmful policing practices and policies. She also works at the Palo Alto Medical Foundation and serves as the Chief Medical Officer of San Diego 211. She works with navigators and to address social needs of San Diegans impacted by chronic illness and poverty in that role. She's also the Director of Equity and Justice for the California Children's Trust, which is an initiative to address mental health access to children and youth across California. Dr. Boyd graduated cum laude with a BA in Africana Studies and Health from the University of Notre Dame, and she earned her MD at Vanderbilt University School of Medicine and completed her pediatric residency at UCSF. In 2017, Dr. Boyd graduated from the Commonwealth Fund Mongan Minority Health Policy Fellowship in Harvard University School of Public Health, earning her MPH. If you don't follow her on Twitter, you should. She just drops such knowledge and perspective there. So without further ado, Dr. Rhea Boyd.
Thank you so much, Dr. Floyd, for that beautiful introduction. And thank you to Dr. Chamberlain and Dr. Schroeder for kindly inviting me today. I'm so excited to be back. Right when I left residency, I did some teaching in the community block for Stanford pediatric residents, and it was a joy. And it's a joy to be here again today. I left my Twitter handle at the bottom of this first slide. So if folks want to reach out to me, that is a very easy way. So today we're going to be talking about pandemics and policing and the intersecting forms of violence that threaten and shorten Black lives, but really all lives in the United States. I don't have any disclosures, but I wanted to start with a disclaimer. You know, today's September 11th, and it is a day of mourning and remembrance for our nation. And I think as we approach this topic of talking about pandemics and policing, I think it's also a time of mourning, honestly, and remembrance for many people in our nation. And so I offer this presentation with the gravity and respect that today offers us. And I hope that we can all remember both those in our country who have made the ultimate sacrifice on 9/11, but also those in our country who continue to suffer the harms of racism that we often tend to forget. So let's jump in. We know in the United States that complex health problems are dynamic. They change over time. And yet we built models that are relatively static. I call that our box. What the box represents are the constraints to what we traditionally thought the vital components of healthcare systems could or should be. We typically constrain that to our biomedical influence on folks' lives. But as we've known for the past couple of decades, as this chart on the right shows, what we actually do in healthcare makes up such a small slice of what determines premature death. And so we've got to rethink what we put inside our professional box. Despite that, we pour a ton of money into our biomedical box, more than any other wealthy nation in the world. For that investment, the United States has overall the worst health of any other wealthy nation in the world. We have a lower life expectancy, a higher infant mortality rate, higher rates of chronic disease, higher rates of obesity, and this is all despite having a population that is relatively younger and relatively less likely to smoke, although the introduction of e-cigarettes is changing our incidence of smoking in our country. What that means is now for every additional dollar that we pour into healthcare in the United States, we are bending the life expectancy curve the other way. This is an aberration across the wealthy world. And since 2014, if you were to drag this curve to 2020, you would see that our life expectancy is now going down. Why is that? Researchers Elizabeth Bradley and Lauren Taylor asked that question in 2013. And what they found was that we as a country spend more on healthcare, but relatively less on social services than the other wealthy nations. As a result, inequality is growing in our country, and our state of California leads the way, where the top 1% of earners make more than the bottom 80%. Part of that is because wage stagnation in our country is profound. If you look at the hourly earnings for non-supervisory employees, for folks who are not the boss, you find that they have barely changed since 1973. Consequently, the purchasing power of our workforce has barely increased over the last half a century. And so the reality is, we are now a part of a generation for whom only half of our children will out-earn their parents. And upward mobility is profoundly shaped by race and gender in the United States. This is data from Raj Chetty, who used to be at Stanford actually, but now is at Harvard, looking at upward mobility by race and gender. If we look at the green map, what it shows is that it pays to be a little white boy who grows up to be a white man in the United States. Because no matter where he lives, he is likely to earn more in adulthood than his parents did when he was a child. Conversely, if you look at the red and orange map, you see that there's nowhere safe, essentially, to be a little black boy who grows up to be a black man. Because virtually everywhere he lives, he is likely to earn less in adulthood than his parents did when he was a child. As the researchers summarized, in 99% of neighborhoods across the country, Black boys will earn less in adulthood than white boys, despite growing up in remarkably similar families. You know, when I present this data, people usually say, you know, I'm not surprised that white boys fare different than Black boys in our country because of our nation's history of racism. And this is where the study is really profound. The researchers held constant many of the common exposures to racism that we consider. These are two little boys who grow up in households with two parents. Their households have comparable incomes. It's not the racial income gap. They have comparable levels of education. It's not the racial education gap. They have comparable levels of wealth. It's not the wealth gap. And these little boys live on the same city block and go to the exact same school. It's not just segregation. So what is it? What they found is that gaps in economic mobility are the smallest in areas with low racial bias among whites, where white folks are less racist, and where there's high father presence in Black neighborhoods. That's not father presence in your home, that's father presence on your city block. So now we have to ask ourselves, what's the relationship between white racism and father presence? And we can think of common, even casual examples, like when white folks call the police on Black people simply for existing in public. Journalist Michael Carriott has called those white collar crimes, C-A-L-L-E-R. And when we usually think of white collar crimes, we typically think about the impact on that individual, the humiliation, the macroaggression, and the risk of police violence and perhaps incarceration. But what we don't often think about is how those same types of crimes can also extract Black fathers from Black communities, and how the impact of that contributes to the downward mobility or the lower economic mobility intergenerationally in Black communities. So this is the pre-existing inequality that already was the landscape of the United States when COVID-19 hit. And if you overlap areas where there are current outbreaks, you see that it maps really closely to areas where the economic mobility gaps for children are the widest in the country. Overall, we know that Black and Latinx populations have the highest rate of COVID cases, that Black and Latinx children make up more than 70% of the multi-inflammatory syndrome cases in children, that Latinx children in particular make up more than half of cases for kids age 5 to 29 and almost half of deaths. We know that Indigenous Americans have a disproportionate mortality rate, and in states like Mississippi for the Choctaw Nation, and states like New Mexico, Arizona, and Utah for Navajo Nation, Indigenous Americans have the highest mortality rate of any other racial, or ethnic group. And compared to white folks across the country, Indigenous Americans have a COVID-19 mortality rate that's more than 3 times as high. But overall, Black Americans have the highest COVID-19 related mortality. It's more than 2 times Asian populations and more than 3 times white populations. So when we see these differences, we have to ask ourselves, is this evidence of a simple disparity, which is a population level difference in health, or is it evidence of an inequity, which is a population level difference in health that is wholly preventable? And because it's preventable, it's unjust. We're going to explore the extent to which these differences are actually inequities. So where do inequities come from? Health inequities arise when certain populations are made vulnerable. I put that in red and bolded it because no racial or ethnic group is innately or biologically more vulnerable than another. Groups are made vulnerable, and that often happens through the inequitable distribution of protections to keep folks from getting sick and the inequitable distribution of supports to ameliorate illness and all of the consequences that accompany illness, like the economic burdens that we've seen accompanying COVID-19. At the beginning of this pandemic, we said what would really shape complications and risk for early death from COVID-19 were chronic underlying conditions, things like heart disease, asthma, hypertension, or advanced age, or poverty. But what we didn't say, and what we now are beginning to acknowledge, is that segregation shapes the distribution of heart disease in society. Discrimination profoundly shapes the racial distribution of hypertension. Environmental racism and disproportionate exposures to areas zoned to be industrial areas or environmental pollutants shapes who has asthma in our communities. How the racial wealth gap profoundly concentrates poverty in communities of color, particularly African American and Indigenous communities. How toxic stress or chronic exposures to cortisol, which is also known as allostatic load, can condition and weather our cells, such that one's chronological age may be younger actually than your cellular age, so that you experience chronic disease or early death earlier. What we missed in talking about risk factors for COVID was the ways that structural racism shapes who's sick and who's well in our country by offering differential access to goods, services, and opportunities by race and ethnic group. This is how inherited disadvantage, not inherited disease, shapes risk for COVID. And that's a quote from Kamara Jones, a beloved pediatrician. All of this outlines how the environment, both the physical and the structural, the legal, the policy environment in which humans grow, learn, work, and play shapes not only our health, but the health of our children and our children's children. We're going to go through some examples of what I mean by this. One is hand washing. So hand washing is one of the simplest and most important ways to limit the spread of infectious disease. And yet race, not income, is the single greatest predictor of access to clean water in this country. We know African American and Latinx populations are twice as likely to lack access to clean water in their homes as white households. And Indigenous populations are 19 times as likely to lack access to clean water in their homes as white households. Here, structural racism is operating through residential segregation and public divestment in Indigenous and Black communities, which disallows them access to clean water and thus shapes the distribution of COVID in the United States. Or air pollution. This is data from a study that came out of Harvard School of Public Health back in May. that said that if you have chronic exposure to particulate matter in the air, it could raise your COVID-19 mortality rate by as much as 15%. But what we know is that residential segregation, suburbanization, white flight, and local zoning ordinances profoundly shape who's exposed to pollution, and particularly concentrates those exposures in African American and Indigenous communities. And as such, we have to understand that that also may increase COVID-19 related mortality for those populations as well. We also have to change how we've been talking about age. Early in this pandemic, we had some public health advisements that would say, mask for your grandparents. And then this data came out again from Harvard School of Public Health that told us that the greatest gap in racial and ethnic groups for your mortality for COVID is between Black Americans and white Americans aged 35 to 44. In that age group, Black Americans have a COVID-19 mortality rate that's 9 times higher than their age-matched white peers. If you go a decade earlier to Black Americans and white Americans aged 25 to 34, Black Americans have a COVID-19 mortality rate that's 7.3 times higher than their white age-matched peers. What we have to acknowledge is that chronic discrimination can weather or silently age and prematurely kill cells. And the folks who are at risk are not just the elderly. They are also folks who have experienced chronic discrimination, such that their cellular age is advanced of their chronological age. So when we talk about the inequitable risk of COVID infection and complications, we're not just talking about poverty or underlying illness, and we can no longer afford to say the risks in those ways. And I put an asterisk next to risk here to remind us that, again, we're thinking at the population level about systematic factors that impact groups of people, not at the individual level where individual choices or behaviors might shape individual risk. At the population level, risks for COVID-19 are evidence of legacies and current practices of racial exclusion, discrimination, disinvestment, and violence that concentrate disadvantage in communities of color, create adversity in communities of color, and shape folks' opportunity for wellness and well-being, and provide conditions for disease like COVID-19. These factors are why we as a nation have a rising all-cause mortality. So the national average is outlined on that black curve in the middle that has the black squares. Those squares indicate inflection points. And since 2013, all-cause mortality has been increasing in the country. That is driven largely by an increase in mortality rates for non-Hispanic white folks that got a lot of interest after 2015. But the highest rates of mortality in this country are absolutely for non-Hispanic Black folks, the yellow star, and for non-Hispanic Indigenous communities, the gray star. This rising mortality is why life expectancy has been decreasing since 2014 in this country. And this is data from Elizabeth Wrigley Field and animation that was put in the New York Times. And despite COVID-19 and the enormous increase in mortality that has resulted, white mortality right now is still likely to be less than what Black Americans have experienced every single year in this country. The dotted line is the projected white mortality and the jump in white mortality that occurred because of COVID-19. The solid black line at the top is Black mortality pre-COVID-19. This chart doesn't even include Black mortality from COVID-19 or Indigenous mortality. So as researcher Elizabeth Wrigley Field summarized, in 2020, what we can expect is that white life expectancy, even amid this devastating and deadly pandemic, will still remain higher than Black life expectancy has ever been. This is what Black folks are up against. And it's why Elizabeth Wrigley Field titled her study, Racial Inequality is as Deadly as COVID-19. So what are those legacies and practices of racial exclusion, discrimination, disinvestment, and violence? When we try to recall them, we often go to this time, right? To the Jim Crow South, when we had segregated public accommodations like bus depots or water fountains. We don't often go to this time. This is a photo in Newark, New Jersey in 1967, in what is now known as the long hot summer of 1967. Researchers call it the long hot summer because during that summer there were 169 race massacres across the United States, all sparked by an event of police violence against a Black taxi driver in Newark, New Jersey. What we don't talk about is what it's like to live in this country and be that little Black boy who's walking down your own city block with your government at your back and your hands are up because you know you're not safe. What we don't talk about is what it's like to be the Black women who line the sidewalk, whose hands are also up, who are not intervening because they are also not safe. Or what it's like to be the little Black boy who's being carried and is looking back at this boy who's just a bit older than he is, who's understanding what it means to be a little Black boy in this country. We don't talk about the ways that police violence shape health and disease in this country. And we don't talk about how little change we have made since that long hot summer of 1967. This is a Pulitzer Prize winning photo by photographer Devin Avalon that covered Time magazine in 2015. It's a picture from Baltimore after there were riots following police killing Freddie Gray. The photographer asked the apt question, what has changed since that long hot summer? And many are asking that question rightfully today. So when we talk about the exposures that contribute to increased underlying disease and thus increased risk for COVID complications and early death, we absolutely have to be talking about police violence. So what do we know about police violence? We know that police kill about 1,000 people a year in the United States. And we know police exposure is a particularly deadly one for Black men and boys, of whom the National Academy of Sciences told us 1 in 1,000 will be killed by police in their lifetime. 1 in 1,000. I always tell this figure to pediatricians because 1 in 1,000 is also the mortality rate for measles. And when you think about the near constant public health surveillance and investment we as a nation have placed into eradicating measles, and you compare it to how little we have done to prevent police violence, you begin to understand how racism not only shapes exposures to forms of violence that shorten Black lives, but how we in healthcare and in public health are also affected by racism and how that precludes us from responding adequately to exposures that uniquely and devastatingly impact Black folks. This is data from our state of California. We're really fortunate to live in a state where we both mandate that police report use of force and that we make that data openly available in our open justice portal. What we know about use of force in our state is that although death is often covered in the media, it is not the most common outcome when police use force. It happens about one out of every 5 times. But what's much more common is serious bodily injury that happens almost 2 out of 3 times. And here's the kicker. This is a question saying, when police use force, why did they come in the first place? And what data from our state in 2019 tells us is that more than half of the time, or about half of the time, the reason police came is because somebody called for help. Just think about that. When police use force, half of the time, it's because somebody was calling for help. And when they use force 1 out of 5 times, somebody's gonna die. And almost 2 out of 3, somebody's gonna suffer a serious bodily injury, like Jacob Blake. Right? This is why advocates are saying that we can no longer call policing a public pillar of public safety because it doesn't keep everyone safe in the same way. And so, just this past August, just about a week ago, we as a state passed a critical bill, AB 2054, which was the Crises Act, which stands for the Community Response Initiative to Strengthen Emergency Systems. If police don't keep us safe, a number of organizations, all listed at the bottom, have asked to be able to create community-based responses to local emergencies, to crises related to being unhoused, mental health crises, intimate partner violence or community violence, substance use disorder, and natural or climate disasters. And this bill provides 3 years of pilot grant funding to see if we can develop alternatives to calling the police for help. That's how critical these changes are. So what do we know about people who are exposed to police violence? We often focus on the victim, and we know the victim is at risk for serious bodily injury, as we've discussed, death, but also mental health impairment, also disability, also arrest, and all of the adverse health outcomes that accompany incarceration. We also know that witnesses are affected, and this is data looking particularly at what happens when youth witness violence. We know they're at risk for poor reported health, physical health, for mental health impairments like PTSD and depression, and for school failure, which also decreases their lifetime earnings, increases their likelihood of entering the criminal justice system, and overall will decrease their life expectancy. We also have to expand the forms of policing that we're talking about, because we know that communities are also uniquely policed by virtue of their immigration status. And children who experience or witness an immigration-related arrest of a family member have higher rates of depressive symptoms. Those symptoms are magnified if both of their caregivers have an undocumented legal status. We also have to start talking about police violence as a form of community violence. And data from Ali Sowell, who really is the leading researcher in the nation on the health effects of police violence, have told us that even if you just live in a neighborhood where police kill someone, you have a higher rate, you have a higher likelihood of having high blood pressure and obesity. And that's particularly true for women who live in that neighborhood. We don't often talk about how police violence affects women, but it absolutely does, both as victims of police violence and those who bear the health effects of living in neighborhoods that are lethally surveilled. For kids, these exposures could be internalized and experienced as caregiver absence if your caregiver is hospitalized, as Jacob Blake is now, or if your caregiver is killed, like Eric Garner was. For kids, it could manifest as a custody transition, or even the criminalization of their friends or of themselves, which shapes what we call their racial socialization, or their relationship to their own racial identity. This is why, for kids, even routine police encounters, whether by quantity, by the number that they have, or by severity, by what happens when they have them, can shape their health. We also know that if parents go to jail, right, kids of parents who go to jail have higher risk of other health conditions, like mental health impairments, like chronic diseases like asthma. We also know that parents being imprisoned also disconnects families from opportunities for employment and public housing. It renders certain parents ineligible for student loans or to vote. And as we approach this critical election, we have to think about how that shapes people's ability to participate in and defend our own democracy. We also know that children, particularly immigrant children, are detained themselves, and child detention has been linked to mental health impairments and to developmental delays. It's also associated with behavioral changes in sleep and eating habits and impaired school performance, which, as we discussed, if it contributes to school failure, portends worse future health for kids as adults. The violence of policing ultimately separates kids from the social networks on which they rely and in which they thrive. And the violence of racism and the various forms of structural inequality that racism creates at a population level impairs and disappears caregivers. This is why racism is a critical root of childhood adversity. The top of this tree, the branches, are the symptoms we often ask about when we ask about ACEs. The bottom of the tree are the roots, which are all also connected to experiences of racism that drive the symptoms that we ask about. Racism is a devastating root of chronic undertreated disease and completely preventable early death. In short, racism kills people, and we have to open up our box in healthcare to rethink about what we're doing about racism, because we know that equality saves people's lives. This is why at the beginning of this pandemic, I wrote an article and put it in Cosmo of all places, because I wanted young people to read it, saying and defending how powerful protest is as a public health intervention. The reason I said that is because we in this country have a history of requiring oppressed groups protest and publicly lay bare their pain for us to initiate massive changes in laws that offer greater equality to populations. And it's that greater equality that ultimately protects folks' health. And that's why protest, even during a pandemic, will remain a powerful and vital public health intervention, and why we as healthcare practitioners have to ensure that when folks protest, they can do so safely. But not everyone's protesting for the same thing. This is a sign from Texas, from a protest there in June. At the end of June, June 30th, when Texas had the highest rate of COVID cases that they had had to date, folks took to the State House lawn and protested a new order from the governor that closed bars. Texas wasn't alone. As we've gone through this pandemic, white folks have gone to State House lawns across the nation to protest public health advisements, to reopen their businesses. And so we have to talk about how whiteness also shapes health and risk for disease in this country. Too often, whiteness is made normative. And so although it's shaping all of our access to resources and power, it's absently present. We don't often name it. And so we're going to name it today. So whiteness is different than white. White is a racial status, which is affixed to a phenotypic skin tone. Whiteness describes a structural apparatus, or the laws and policies that shape who has access to advantages or disadvantages by racial group. Whiteness works to use laws and norms to empower, normalize, favor, and reward white people as a population. This is important because sometimes when I present about whiteness, folks say, well, don't individual white people also face hardship? Absolutely, they do. And we should respond to those individual hardships with the same compassion and urgency we would respond for any individual hardship. And yet, I use this picture of someone getting a boost over a wall, because how whiteness works is it gives white folks as a population, despite your individual hardship, a boost over some of those hardships. One example would be that compared to white populations, Black populations are more likely to have less income at every level of education, less wealth at every level of income, and higher rates of unemployment, especially during the pandemic right now, at every level of education, right? These are ways that your racial status and how laws entrench those racial status in access to resources shapes who has advantages and who has disadvantages. So what do I mean when I say whiteness more specifically? I'm referring to 4 specific forms of racial exclusion and discrimination. Those forms are white hegemony, white supremacy, white privilege, and white normativity. And we're going to go through a definition of each so you can now use these terms in your own work and practice. So white hegemony refers to forms of racial exclusion and discrimination that establishes and enforces racial hierarchies in which white people nearly exclusively hold decision-making power. The US healthcare industry has a white hegemony. 91% of our CEOs are white. White supremacy refers to forms of racial exclusion and discrimination that creates and maintains a racial ordering of humans and resources that reinforce the racial dominance of whites. White supremacy often does that through violence or deprivation. White privilege refers to forms of racial exclusion and discrimination that preferences white people through disproportionate access to resources associated with mobility. And we saw the economic mobility gaps early in this presentation. White normativity refers to forms of racial exclusion and discrimination that naturalizes power asymmetries between white and non-white people as primarily meritocratic. This is when we say that the reason our intern class is predominantly white is because those applicants deserved it more. The reason white folks have predominantly more power is because they have more degrees and more qualifications that make them more deserving, right? We naturalize something that is wholly unnatural and is structural in creation. And so we have to contend with what Jonathan Metzl taught us. This book came out in 2019. It's called Dying of Whiteness. And full disclosure, I did a review of this book for The Lancet, and I agree with his central premise, which is that whiteness and the racism whiteness engenders at a population level isn't just bad for Black folks or Indigenous folks or immigrants or Latinx groups. It harms the health of white folks too. It does that by creating levels of scarcity, resource scarcity, by saying if you want white folks to have certain advantages, you have to take those advantages from other people. But when you try to take them from others, you end up undermining the resources and the public goods, frankly, we all need to be well and to thrive. And so what should we do to adequately respond at scale to racism as the public health crisis that it is? We as a field have to move towards and contend with abolition. What does it mean to abolish racism? I'm going to go through 4 things that I think we need to start thinking about and doing urgently to abolish racism. The first is truth, reconciliation, and reparations. Wealth redistribution. We need more robust safety net systems, and we need to expand access to public goods. Let's start with truth, reconciliation, and reparations. Just this past July, our own American Academy of Pediatrics released a public statement acknowledging the times in which they were less than welcoming and exclusionary towards the early Black members of the Academy. But truth and reconciliation is insufficient without reparations. This is a quote from fellow pediatrician, Dr. Mona Hanna-Attisha, which many may know from Michigan State, as she highlighted the atrocities and the Flint water crisis. As she says, surviving life's hardest blows should not be celebrated or even expected. Recovery and reconciliation require reparations and resources. To expect resilience without justice is simply to indifferently accept the status quo. And so truth and reconciliation must always be accompanied by reparations. What we're telling the truth about is the specific ways in which our organizations or our institutions have created harm and contributed to racial inequities. What we're reconciling about is saying sorry for those things. And then what we have to do once we acknowledge those specific harms is work to specifically repair them. One form of repair absolutely has to be wealth redistribution. One reason is because we know how wide the chasm is between white and Black folks in this country. For example, for every dollar of wealth held by a household with white children, we know households with Black children have 1 penny. There is no getting rid of the effect of racism on the lives and futures of folks of color without addressing the disproportionate distribution of wealth in our society. One way to address that distribution is to divest our collective resources from punitive and violent institutions like policing and to instead invest them in a care economy. Care Not Cops is an organization in Portland that their platform is Divest Invest. And what that means is that if we want to both prevent crime and prevent all of the injuries and harms associated with policing, that we as a nation, and Portland as a city in particular, have to take money from those structures and invest them in caring economies, both within healthcare, but more importantly, within caregiving, to nurture the relationships that really help kids thrive. We also need more robust safety net systems. We're fortunate that now Missouri has expanded Medicaid, but there are still 12 states that have not. The pandemic has only made more clear how we need to invest in public education, not just now, but forever. And as we've seen growing food insecurity, how we have to strengthen our nutritional supports. All of which are exposures that also uniquely affect folks of color because of public divestment in their neighborhoods. We also need an expansion of public goods, resources that everyone benefits from. We need not just an expansion of Medicaid, but universal health care, such that insurance is no longer a barrier to access to care, and so that insurance no longer tiers care by racial and ethnic group. We need universal basic income so that folks don't just fall on hard times, so that we ensure people always have the resources they need to care for their basic needs. And the pandemic has only made more clear that we need universal internet so folks can safely, remotely work from home, remotely learn, and receive remote healthcare. So we have to move to abolish racism from every institution, every practice, every policy, and every social norm in which it operates and too often hides. The future health and well-being of our children and our children's children will absolutely be measured in how well we succeed in this. One path forward, and I'll just cut to the chase, would be to think more, not just about how we're offering equality, not just about what equity means, but about what it means to participate in a liberatory politics, or even to offer communities love. So equality, right, would offer everyone the exact same thing, and universal healthcare would do something like that. That would be immensely beneficial for certain populations, but it wouldn't prevent the barriers for other populations from accessing care, because we know care isn't equally available based on, for example, where you live in the country. So we might take a more equitable approach. During this pandemic, we could think specifically about offering universal testing for COVID in communities plagued by segregation, because we know segregation drives risks for underlying illness. But even that isn't enough, because we know that even if we tested folks, they're still going out into the community and being disproportionately exposed to pollutants and working conditions that place them at risk. And so a liberatory politics might ask that we also advocate for worker protections, paid sick leave, hazard pay, and the adequate distribution of PPE. And I've been proposing that we also should start thinking about what it means for us to work in a caring system that is not yet providing love, What I think that means is that we seek to provide love. And one way we could think about doing that is sharing PPE. Sharing PPE is a powerfully anti-racist solution right now to some of the inequities we've seen emerge from COVID-19, because we get the lion's share of PPE in healthcare, and our workforce is predominantly white at every level. And yet there are other essential laborers who work in supply chains that are vital that don't have equal access to PPE. And so even in a time of our own shortage, which might sound wild, but that's why it's love. Even in a time of our own shortage, we have to ensure that we are equitably and equally sharing PPE. I think love has to be the metric by which we measure our health system's performance, how efficacious our delivery structures are, and the ultimate impact of the care we're really seeking to provide. I want to end on this note because I think we're approaching a time in our country that is absolutely critical and will define our future. I think voting is extremely important, and I hope everybody has made plans to vote on either election day or by mail, as our state has made more easy for us. This really has to be our greatest hope. I think despite the time, it's important to end with the words of our visionary Brian Stevenson, who's a lawyer who works at Equal Justice Initiative, who reminds us that hope is our superpower. We can't let anybody or anything make us hopeless. Hope is the enemy of injustice. Hope is what will get us to stand up and to vote when other people tell us to sit down and try to take our rights. I'll end there and open for questions. Thank you.
Thank you so much. That was just incredible. I've been getting lots of text messages how brilliant it was to invite you to come join us this morning. So thank you. Baraka, do you want to lead the discussion? Maybe take a look at some of the questions. There's some great ones. We'll get you to unmute.
That would be wonderful if I'd unmute. So our first question is, how do we move from protest to action?
Sorry, I'm hitting myself 1 second. You know, I might reframe that because protest is a powerful action. Protest is a powerful action. Just think about what has happened since Black Lives Matter started after, the murder of Mike Brown in 2014. Like, we have shifted how we talk about policing, how we understand policing as a public health crisis in this country. Black Lives Matter has changed everything. There was just a article in the New York Times that said Black Lives Matter might be the largest movement in US history. There was a day that more than 20 million people protested at once just in the United States. Every single state had a protest after the murder of George Floyd. Even rural areas, even areas that were predominantly white and had monuments to the Confederacy and to white supremacy. Protest is an action. And because of protest, we now have an agenda, the Movement for Black Lives. And that agenda has laid out a clear plan for economic, racial, and electoral justice. And included in that will be health justice. So I would say protest is a really powerful action that we have to continue and participate in as clinicians.
All right, thank you. Related to that, how can we not lose focus on protest safely while we protect the communities and individuals from the aftermath of some of the protesters, and I'll add in there agitators who've been violent?
This is why I think it's really important for clinicians to speak out about how much protest matters and how we can be a part of keeping protests safe. So one of the things that during this pandemic made protest a risk, right, for COVID is that people would then be gathered in close quarters and shouting and singing and, sending droplets into the air. And so we wanted to advise people to wear masks, to adequately space, to only protest in the outdoors, which is really important, to carry hand sanitizer. The protests I went to, folks were bringing around hand sanitizer, bringing around water, we could test people at protests, frankly. If our nation ever increased our supply of tests to everyone, that would be the right way to use them. And then there is something also really important to say about white vigilante terrorism, that part of the power of protests, part of how we understand the power of protest is the level to which people are willing to try to take away that constitutional right from folks, right? Like by having events of terrorism happen at a protest, it's trying to scare people from doing what we need to do to keep everyone's focus on racial injustice. And so I think also having clinicians nearby in case there needs to be first aid delivered can be very critical at protests. And institutions like Stanford would be incredible to set up tents like that.
Related to that, we see a lot of uprise of folks who are feeling threatened and worried about the Black Lives Matter movement. How do we see these individuals?
That is an interesting question. I think what it might feel like, how I've heard other people say it, is that if white folks in this country as a population have had disproportionate advantage, equality could feel like they're losing something. You know, when you try to even the playing field, it could feel like a distribution away from them. But I think what we also have to acknowledge is that this isn't zero sum. The United States is enormously wealthy. There are more than enough resources for everyone to have something. And it's why we need to invest in public goods to make that a reality for folks. We could have universal healthcare. We choose not to. We're the only wealthy nation that doesn't. And when we approach it in that way, then there is nothing to feel threatened about. Racial equality makes everyone healthier. And just as, Jonathan Metzl said, white supremacy is killing white folks. And we need doctors who also have the courage to stand up and say that to white folks, so that we all can move forward as a civilization.
Yeah. Another question about how to redistribute wealth. Are there any suggestions that you have for how to begin to do that?
Absolutely. One is reparations. I am a staunch proponent of reparations for the descendants of American slavery. I think, and those descendants don't just live in the United States. Slavery is a transnational project. So descendants of American slavery, period. That could look like a check from the federal government. That could also look like specific policies at institutions. For example, Georgetown as a university said, we can actually trace back the families that built this university. And those descendants can get scholarships and have a special admissions consideration for the university. So one great way is reparations.
Thank you. Another comment, protest is a powerful tool, but I do see folks going to politicians' homes, such as Mayor Breed, who are progressive, and talking about Black Lives Matter, who are white. I just wonder about taking protest as a weapon of intimidation.
I love all these questions about protest. Protest is meant to be confrontational. That confrontation isn't meant to happen just between individuals. It's confrontation between portions of our body politic. The reason people would go to a politician's home isn't just for that individual politician, it's for the optics of saying to the government, and that person who's that politician represents your government at whatever level they are, like, this is a problem for us. Although I would never advise actual individual harassment, I think that confrontation between our body politic and our different institutions that represent us is really critical. And our elected officials should create opportunities for more of that dialogue. And one thing I'll say about white folks participating is it's hugely important. I think it's what makes this moment different than the other moments, right? We have a multiracial uprising right now. These aren't just Black mothers who are on the line, who are the first mothers who have been on this line since Mamie Till Mobley, but this is white mothers in Portland. This is Moms Demand Action. There are folks of all racial and ethnic groups who are acknowledging the intersections of this violence, not just for Black lives, but for all of our lives. But the ways that we have to confront it is to acknowledge the disproportionate toll it takes on Black lives. And so I welcome the participation of white folks in those protests.
So moving kind of to think about inequities, what do you think it looks like to address the racial health inequities through love beyond the pandemic?
Gosh, I think a better question is, what does that feel like? what does it feel like for us to offer love as providers? And what does it feel like to patients to actually receive that? Like, when you're in an experience where it's loving or it's toxic, whether you feel safe or you feel vulnerable. And I think we have to tap more into how we elevate that type of an experience in healthcare, which may not look like the same technical, mechanical way that we approach other quote unquote quality improvement. And I don't think just because it looks differently than that it makes it any less valid or righteous. I think we have to think differently about how we're approaching this because we've gotten it wrong so long.
Yeah. Related, is there a way we can, as organized medical staff, lean forward to supporting social determinants of health and divest in the biomedical institution that worsens health?
Ooh, great one. Yeah, I mean, there's many ways. One way that we're all doing that we can continue to do and invest more in is shifting our clinics to also be sites, to co-locate other critical basic resources at our clinic sites and make them freely available to folks. Stuff like food, stuff like housing referrals. I think that's really important. I also think our institutions are enormously wealthy, mine included. PAMP is so rich, and we need to be devoting more of our resources to communities that we've historically and currently exclude. Like, what are the ways that we offer healthcare to people in ways that they can actually receive it? And sometimes when we require that people have insurance, we close the door to too many folks. So I also say, I think we should give out, frankly, more free care. And then we as clinicians should absolutely vote and support universal healthcare, which hasn't always been the case in our history as a profession.
And then we're almost at time, but I want to get two more questions in. What are your top priorities for child policy approaches to structural racism?
Eliminating segregation. I just tried to write this into a national policy, honestly, and I'm having a lot of back and forth. So I'll just say to you, we have to get rid of segregation. There is evidence to suggest that if we get rid of residential segregation, that you could close the income gap, the wealth gap, and the education gap, which would then close the employment gaps. Like, segregation is a profoundly harmful exposure. And there are ways our nation in the past has moved towards desegregation that we need to do again in our workforce and in society. I can give one example. So how we desegregated hospitals is the federal government said, when Medicare passed in 1965, they said, you can't get federal funding for rebuilding your hospital or for anything you do in your hospital unless your hospital is desegregated and sees people despite their race, right? We need similar laws like that. You shouldn't be able to get funding for your hospital if your workforce is 80% to 90% white, because we can't have that anymore. Because as soon as we exclude people from our workforce, and in many areas where the number one employer your healthcare institution is or your medical center is, like, that also is shaping who's poor, who has jobs and who doesn't have jobs, right? So segregation, we've got to get rid of it.
And then the last one, do you have any information on what's been tried regarding anti-racism training for police officers and what opportunities might exist there?
Great question. So here in our state, our American Academy of Pediatrics, I actually authored our support. So we passed a bill that had our peace officers, which is what we call police officers in the law, receive like implicit bias training. So it has been tried here in our state and here in San Francisco, even more specifically. And it's completely insufficient and in some degree ineffective. Like, implicit bias training focuses on the interactions between individuals. Anti-racist training, the same. It says that you as an individual are going to learn something different and then you're going to act differently. But what it doesn't recognize is how police violence is a systemic problem. It's systematic. It's because police carry militarized weapons, right? Even if you wanted to shoot somebody, you couldn't if you weren't carrying a gun. You couldn't tase somebody if you didn't have a taser, right? This is why other countries don't have police shootings, because their police don't even carry weapons. So we have to rethink about how we equip police officers, who we recruit to be police officers, and the roles they serve in society, which is, you can't train that away.
Yeah. And then the last question is, could you discuss implications of Isabel Wilkerson's exploration of case as the operating principle of racism to what an abolitionist politics would look like.
Woo, you guys are, I just got my book Cast in the mail the other day, so I'll say I haven't read it, but I did read her New York Times piece on it. So essentially what she's offering is that in the United States, we have a caste system similar to the caste system that maybe we're more familiar with in India, where people are relegated to like a hierarchical society and you cannot move between those levels of caste. I think what it means in terms of abolition is we have to think about what it would take to functionally abolish caste. And what I mean by functionally is, I don't know, my own experience tells me I may never live in this country at a time when race is not one of the most powerful determinants of who has power. And yet we could shift it such that it's not a determinant of who has resources. And I think that's the place where perhaps we should begin. And that might begin to unravel our relationship to caste kind of interpersonally, because it makes people feel good to be on top, frankly. And that's why, to somebody's earlier question, why some white folks feel intimidated, because it feels good to be on top. And our relationship to caste as a system that profits enormously off the inequality that we have.
Thank you so much for this insightful talk today.
Thank you so much.
So I just wanted to add, I hope that the questions make it clear that the passion in this department, we have to tap into it even more than we already are. I hope you know that it was our residents that organized the school-wide Black Lives Matter protest right after George Floyd's murder, where both CEOs and the dean knelt with all of us for that excruciating, was it 8 minutes and 46 seconds? But the energy and the passion and the sophistication of this group is extraordinary. And we're really trying to find more and more ways to tap into this. We believe pediatrics should lead the way in this area because of the impact. And so just so you know, we just announced that the Maternal and Child Health Research Institute is funding grants on research on the impact of racism on maternal and child health. So my phone is flooded with texts and messages saying, we need more of her. So I'm hoping that Baraka and Lisa Chamberlain and all of us can find lots of opportunities to work with you in the future, because everybody's very inspired and it was just a wonderful way to kick off the new year. So thank you for joining us today.
Thank you so much.
Okay. All right, the last thing is somebody asked me if we can publicize this. I have already sent the announcement about this to the CEO of the hospital and the CEO of the foundation. What I will do today is once we have the link to the recording, we'll send that out to everyone, share it widely, send it to your friends at children's hospitals or foundations or organizations across the country. We also share these sorts of things with people like the Dean of the School of Education, people in the School of Law. We really want everyone on the campus to know about these incredible presentations and then think about how to work with us to advance this, to continue to advance our work in this area. So yes, we will promote this widely. Great. Thank you. Thanks, everybody.
Thanks so much.
Have a great day. Thank you again, Dr. Boyd, for joining us.
Of course.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.